Recording in progress.
Hi, everybody. Welcome back to the Gestalt Get-Together. I'm so excited to have you here, especially for a guest who's become quite a good friend of mine over the years and has influenced this podcast a lot. If you're joining here tonight live, thank you so much. I do want to make sure that you get credit tonight. So after you finish this stream, please go over to SpeechTherapyPD.com to make sure that you get credit. But if you're listening later and you're not a member of Speech Therapy PD, please feel free to use my code Gestalt33 so you can get this episode for free. You're already listening to it. Make sure you get that credit so you're not panicking in December to get all of your hours. So what's important for me is to give my financial disclosures. I am the owner of my private practice, Crescendo Communication. I sell online products and online courses. I also do receive compensation for the episodes of the Gestalt Get-Together. I want to introduce my guest tonight, who is Michelle Dawson. Michelle, I'm about to talk you up. Are you ready to hear all of your experience again?
Nope, I'm internally dying, so I'm going to sip my tea.
Okay, so guys, Michelle has the most letters after her name that I've ever seen. You ready? Michelle Dawson. I'm going to do it. So I listened to your podcast for a long time, back when I commuted from Baltimore to DC. So in my head here, Michelle Dawson MS, CCC-SLP. That is burned in my head. All right, you ready? CLC, BCS-S, FNAP. All right, so here we go, guys. So you know a little bit more about who I'm talking to today. We are talking to someone, and maybe this is, I don't know if this has been updated. I took it from Speech Therapy PD. Works for Augusta County Public School as a full-time early intervention speech language pathologist with the infant and toddler connection of Augusta Highland in Staunton, Virginia, and an adjunct professor at North Carolina Central University. Wow. You're also the host of First Bite Fed Fun Functional, which is a speech therapy podcast that addresses all things of pediatric speech therapy and presented by Speech Therapy PD. What a coincidence. And then you're also the author of a book, Chasing the Swallow, Truth, Science, and Hope for Pediatric Feeding and Swallowing Disorders. So those are some of your big ones. Anything else you think is important for people to know about you?
I am neurodivergent. I have so much ADHD that, bless her heart, the psychologist let me score and norm my own assessment in front of her graduate student. And she was like, oh no, I've already talked to her doctor. We know what's happening here. And I was like, that's amazing. And I am a wife and a mom, and I have a dog named Waffles, and bless her heart, she will burst in and join us at some point in time because puppy. And I have two neurospicy children of my own, which has just been Goose and Bear, which are not their given names, but their nicknames, and they've hell's bells. Goose was even baptized Goose. So this is how we're going down, and yeah, life is good.
Would you say feeding is your jam?
Absolutely. This is it brings me so much joy because I get to focus on the healing and the collaboration between a caregiver and their tiny human. And I get to be the advocate and empower them through the PFD lens for like interprofessional practice. And so, first and foremost, PFD, then interprofessional practice, and then actually AAC. Because as you and I've talked, I can't work on feeding if the tiny human can't communicate to me what's going on. So, yeah.
Okay. I think that positions us well. So feeding's your jam. Feeding is not my jam. I like to joke that I will make it worse. And so I was excited to have you on and try and find an overlap for us.
Yeah.
I wanted to have you on the podcast, but also so I can do some learning when it comes to feeding. I feel very intimidated, even though, as we're going to talk about, it's a really important consideration for autistic kids who then think about like Venn diagram of those we identify as GLP. So feeding and GLP.
Yes.
So for me, I definitely want to do a lot of learning. My questions for you are going to be very genuine. And then also for those of you who are joining live, please do not hesitate to ask questions in the chat, especially if you have, if we want to do like a mini case, throw in some information about a client who might be stumping you, and then we can talk about it live here and maybe give you some ideas. So don't be shy about the chat. Okay, so I want to lay out our outcomes for this episode so everyone can be prepared for what those are. So the first one is be able to define pediatric feeding disorder.
Mm-hmm.
Number two, list at least two etiologies for PFD. And then number three, which I feel more equipped to talk about, describe at least three strategies in feeding therapy that leverage linguistic or cognitive gestalts to help the child. So that's where I'm going to come alive. But let's get started with the stuff that makes me nervous. What is PFD?
Oh, oh my heavens. That is the million-dollar question that has been defined and then attempted to be summarized essentially for the last 10 years. Okay, so I have to preface this with I am the old lady in the room. I am having this framework I have practiced for almost 20 years. And pediatric feeding disorder as a consensus paper, as a definition, has actually only been around since 2019. And it's important that we understand our history because that gives us the foundation with which to practice, right? So, for everybody else that's older and Botox and gently graying, we learned oral or oral pharyngeal dysphagia, or maybe a tiny human head difficulty with the oral preparatory stage, like hand to mouth, right? But that didn't capture what we were really seeing with the little ones that we'd get referred. I'd get referrals for failure to thrive all the time. And I'm like, okay, well, that's just a fancy diagnosis for we don't actually know what's going on. Or sometimes a patient would come with the diagnosis of R63.3, which is just feeding difficulties. Well, that doesn't tell me a hill of beans as to what's going on, right? There's nothing here to this diagnosis. So, Feeding Matters is the international nonprofit that they're the reason we have this diagnosis. And the timing of today's episode and our conversation is perfect because May is International PFD and ARFID Awareness, and there is an overlap there. And and so I'm going to encourage everybody, if you're driving, don't do this now. And if you're running, maybe wait till you pause. But then go follow Feeding Matters on Instagram, on however you consume social media, so that you can stay abreast. But Feeding Matters was originally founded as something called Popsicle. And that was like a million years ago. And Popsicle was created by a mom who had a hurt. She had children that had cerebral palsies and essentially struggled with getting her children to eat. So she went to a bunch of different physicians and specialists and mom shamed, mom guilt. It's your fault. You're the reason that your children can't eat. My door slammed in the background. Even the wind agrees with this. But tell a mom what they can't do or lay on some mom guilt and then watch a woman rise. And so she took her hurt and she created Popsicle that evolved into Feeding Matters. And in 2019, they've created the actual consensus paper. It's by Gaudet et al. Actually, Dr. Amy Delaney, who I like fangirl, everybody go follow Amy Delaney at Peds Feeding at Marquette Lab. She's at Marquette University. She is one of the world's best researchers on pediatric feeding and swallowing disorders. She's one of the co-authors on the paper, and they defined pediatric feeding disorders having 4 domains. So what that means when we chart as a speech pathologist, I have to chart within my scope of practice according to the medical domain, according to feeding skill, according to nutrition and psychosocial. Now that's kind of where it gets a little tricksy because in order to get a PFD diagnosis, you only have to have one of the 4 domains impacted, right? So I'm going to give a very honest, raw comparison, and I'm hoping that this will help it make sense, okay? All right. So, Corinne, have you ever had food poisoning?
No, I feel so lucky though.
What?
I know.
No.
Unscathed.
Unscathed.
I'm gonna get it tonight. That's what I
Okay, no, don't jinx it. Okay, so then I will tell you my fun food poisoning story because this honestly happened. Okay, so I went to Rhode Island. I was actually up in Providence to give a lecture. It was like the 3rd day of like a 4-day travel tour to do a lecture on pediatric feeding disorder. So I'm up there with my girlfriend, Cheryl Sylvia, who is this petite, sassy little like Miss Rhode Island SLP. And she's Portuguese. So she takes me to a Portuguese restaurant. And this is back when I ate meat, actually, one of the contributing factors to me stopping eating meat. And she ordered like authentic Portuguese red wine. And trust me, there was copious amounts of the Portuguese red wine. And then she ordered the flaming wiener. And I kid you not, it was a sausage. And they poured, I don't know, lighter fluid on it. And they lit this sucker on fire on the stage. And again, Cheryl's delightful and I love her to pieces. And she's like, little one. She always called me little one. She's like, don't blow. And I was like, that's what she said. And she's like, no, you'll literally burn the building down. And I was like, okay, fair.
Michelle.
Oof, it was
Ooh,
great.
geez.
So we behaved, didn't blow the building down, and we ate it except for the bite in the middle. And she goes, little one, she's like, don't eat this. And I was like, why? It was so good. And so, of course, I ate it because I thought she was fighting me for the last bite. No, it was raw. It was undercooked. Uh-huh. Um, I had very negative sensory experiences later that night of a large amount of hyperemesis, like scary movie vomit. For those of you that aren't familiar with the word emesis, definitely lost a few pounds. Slept on the bathroom floor at the hotel. Woke up the next morning and gave a 6-hour lecture. We survived. But I experienced all 4 domains, right? I had a medical etiology of food poisoning, um, psychosocial component. I will never eat a flaming wiener or eat wieners with my girlfriend Cheryl ever again. I had nutritional choice of, I subsequently gave up meat. And feeding skill, I mean, that was not necessarily compromised. I could cut it, but I mean, if there'd been more wine, we wouldn't have been able to. So that's a fun story, true story, but a really good analogy, right? Now, let's tie this back to the little ones on our caseload, right? Uh, over the course of my career, the bulk of my caseload has been in early intervention. And here in Virginia, early intervention is birth to 3. In South Carolina, it can go up to 5. In some states, early intervention can go to 6. I've also worked in private practice and set up feeding clinics at universities, which is just one of the most exhilarating things that you could possibly do, create a framework for the next generation. And in those settings, I've worked with older children. But what I see time and time again is that academically and clinically, the opportunities for graduate students and younger clinicians to be formally trained in understanding pediatric feeding disorder is actually an outlier. If we look at it from a academic barrier, very few graduate programs actually have a dedicated pediatric feeding disorder class. Most students are exposed to a one dysphagia class, and historically, that's taught by an adult dysphagia faculty member because that's where the money is for research, right? I'm not faulting it. It's just those are the parameters through which our world works. Also, trying to cut your teeth into the world of PFD for a practicum, it's incredibly competitive.
Yeah, I remember there were 4 spots in my program. Cutthroat,
Yeah,
absolutely cutthroat.
yes. And the hardest part for me is that so many graduate students think that you have to do this in the NICU or that you have to do this inpatient in order to have the feeding experience. And you want a real challenge? Do this in EI because I get 0 medical records and I have to be the boots on the ground, empowering the caregivers to engage in interprofessional practice for those 4 domains, right? So those are all of the barriers. That's the lay of the land, but the tiny humans in the cases. So um, I'll give one example of this sweet little guy I'm working with right now, right? He came to me after a pretty horrendous PICU stay, pediatric intensive care unit. Unknown etiology at the time. He just kept getting pneumonia. When I picked him up, he was 18 months, and we've been at it for a few months now. It turns out that his medical etiology, so if I'm looking at my 4 domains, his medical etiology is Down syndrome. That's primary medical etiology, okay? The reason that we kept having aspirating events, so we had a compromised feeding skill. He couldn't latch on a bottle. We just weren't gaining weight. It was just unsuccessful. His feeding skill was a direct result of laryngomalacia, which is a floppy airway. He also has enlarged adenoids. We have narrow nasal turbinates. So like the 3, I don't know, they look like cavities in your nose that you run a tube through when you go to do a fees. His are very narrow and swollen. All of these components work together to give him an aerodigestive tract, like a compromised aerodigestive tract. So he struggled with timing, suck, swallow, breathe, and he kept aspirating.
Can I just, because we do have parents who listen to this after,
Yeah.
can you define aspiration?
Yes, absolutely. So there's overt aspiration, which overt aspiration is coughing, sputtering. It sounds like something's in his throat and you want to clear the throat for him. Um, to those of us that are older, we were taught watery eyes and runny nose could be a sign of overt aspiration or silent aspiration. Now we know that that's not a thing. It's just some people just are extra leaky would be a good way to describe that. But yes, the catch is with certain subpopulations, silent aspiration is a risk factor. And so with silent aspiration, we don't know that the food is technically going into their lungs or the liquid is going into their lungs because there's no coughing, gagging, sputtering, change in voice. And for PFD, the known risk factors for that would be little ones with compromised genetic conditions, little ones with brain injuries, like hypoxic ischemic encephalopathy, HIE, an anoxic event or lack of oxygen, a bleed in the brain, and our congenital heart babies. Our CHD warriors are so at risk for silent aspiration because of the vagus nerve, man. That sucker innervates your heart, it innervates your GI tract, and it innervates your larynx. Fun fact, if your little one that is a heart baby and they start having like weird vocal changes, that could be an indicator something's going on with their ticker too. So, yeah. But was that helpful? I get excited and then go
No,
14
no, it's
different.
great because so the aspiration piece of it, we got to the part about the lungs, about like what that
Yes,
actually
yes,
means.
yes, yes.
So I think that's important. And I like that you talked about the like the overt signs too, because and I think it's very important to say right now before we go even deeper. Michelle and I are speech therapists. Parents listening, we are not your speech therapists. And so we are talking about what we see, our clinical opinions, our perspectives. Anything you hear on this that makes your ears prick up, you need to go talk to people in your area about this. It cannot just come from us. So I just want to give that, like, we are SLPs, we are not your SLPs. Michelle's a feeding therapist, she's not yours. So just very important to keep that in mind. Because you might come away with like interesting information here, but we don't want you coming away from this panicking and being like, oh my gosh, my kid is PFD. Please go talk to your people about that.
Yes.
Let's bridge into talking about autism. And so in EI, because I started in EI too, you're probably going to have a big part of your caseload be autistic kids. So tell me just kind of bird's eye view, like,
what do I see?
Yeah, what do you see? What's that like for you?
Okay, so bird's eye view. In early intervention for the tiny ones, like birth to 3, no, and I'm not going past like 5 and 6. We see, and God, it's literally it's called, it's not picky eating, but that's what we see is it's picky eating, but like, it's not picky eating. We don't have picky eaters. Our children are so brilliant that even at that young age, they select their foods that they feel safe with, right? And if they don't feel safe, they will avoid it. And the beautiful thing is I get to go in and figure out the why. And so if somebody tells me, oh, they only eat this chicken nugget from this particular restaurant, they only eat this one cracker, and we might only poop like once a week. Okay, I'm your girl. Let's go. But like buckle up because we are going to pull in all of the interprofessional practice partners and we're going to figure this out. But it's the why. And that's what's exhilarating to me is our there's always a why, which gets back to that medical etiology. So you're seeing the feeding skill of they probably don't know how to use utensils at 2.5 years of age. They might only use one sippy cup. You're seeing the nutritional status where our self-limiting of our diet is down to this tiny little few trace amounts of food, right? What we know from the research is consistently that the GI gut, the brain mouth gut component in our autistic population is so compromised. And it becomes a chicken and the egg situation, right? So there's a couple of really good resources that I want folks to, again, don't do this when you're driving. One, there's a to die for adorable book simply called Gut, G-U-T, Gut. It's written by I think she's a German gastroenterologist, and her sister-in-law actually did the artwork, the designs. It's very Shel Silverstein, so you'll kind of appreciate it. But what she talks about is how if we self-limit our diet, our gut bacteria tells our brain through the lymphatic system to pursue certain foods. Because that self-limiting of the diet actually creates the cycle where there's less and less variation in the GI tract, right? And our gut is our second brain. So it becomes this perpetual, if it wants sugar, like if there's certain microbiome that want sugar, well, a quick way to get sugar is to eat crackers, to eat French fries, because the carbs dump into a quick, fast sugar. And unhealthy microbiome grows, and you don't get like a robust variety like you would if you regularly consumed pre-fermented foods like kimchi or sauerkraut, right? Which is probably not going to happen for a lot of our kids. If you look at it from a different perspective, there are known comorbidities within the autism population that are pretty significant contributing factors. One is our congenital heart defect kiddos. It's as high as 33% of children that have a congenital heart defect will have a dual diagnosis of autism. And there's cool research out of Harvard, and I need to get you, I'll get you the links on this. But they don't know at this time, is it the immune suppressant medications that the child has to go on to prevent, rejecting the transplant, that causes, the epigenetics to tip over, and now we have an autism diagnosis? Is it the time that the child is sedated for the transplant and essentially their heart is stopped and that medication that's tipping this? Or was it a known comorbid diagnosis based off of like whatever genetic condition that resulted in the heart? Additionally, our little ones that have Down syndrome, 1 in 4 can have autism, but also 1 in 4 individuals that have Down syndrome have celiac disease.
I didn't know that. Okay.
Yeah. And
Yeah.
so there's all of these little outliers. So when I'm working with my little autistic friends, I'm like, hey, deep dive me. Tell me about your past medical history. Tell me about your family's food allergies.
Mm,
Take me from your mom's pregnancy. If the mom has an autoimmune disease, increased likelihood that they will.
mm,
But once you hit that 5 to 6 year old moment, that's when we start tipping into, okay, did the child's baseline pediatric feeding disorder evolve into an additional diagnosis of ARFID,
mm,
which you and I would go to ASHA jail if we gave an ARFID diagnosis, right? I don't want to go to ASHA jail because ARFID falls on the DSM-5 category, so only a psychologist or psychiatrist can give that diagnosis. I cannot. I can say, hey, that psychosocial domain, I am seeing this child struggle with anxiety, but I can't diagnose that. And Feeding Matters has tools for that. Also, they have this smashing directory. So, like to what you said earlier, I can't be your child's feeding therapist, right? Unless you're in Stanton or Augusta Highland counties. And then, yeah, absolutely look me up. But if you type in your zip code, you can find somebody who's either an SLP or an OT or a psychologist, or like if you need an ENT, a GI, you can type your zip code in. And if somebody is in your area, you can find them there for free, which is amazing. So, yeah.
Yeah, and I put the link in the chat to Feeding Matters for those of you who are here live, and that will be in the show notes if you're listening later on a streaming platform. So if any of this is catching your attention, whether you're a professional or a parent, please go check out the website. There's a lot of really good information on there and some free resources.
Yeah.
I was on there earlier today, and there's a lot of good stuff.
Yes. On the specifically for the caregivers that are listening, in the top left-hand corner, there's a button that's bright orange, and it says Get Help. If
Mm,
you click that button, there's a free program called the Power of Two program, where one caregiver who's gone through training can be your free caregiver mentor.
cool.
And like, you have the families that like they want to pick our brains professionally, but they also need a safe space without alphabet soup on their names. how empowering is that? Where you can just like go and have like a joyful mom event or like an angry mom event, and there's no judgment because they get it.
That's great. I love that. Like peer-to-peer support.
Yes.
That's great.
Yes.
Um, I'm curious about you. We talked about some of the potential etiologies there. We talked discussing that greater definition of PFD, and I did put in the chat as well a link to that consensus paper. Again, that will also be in the show notes if you're interested. But I want to talk about, you mentioned the AAC side of it. So you're engaging in feeding therapy with an autistic child, working with the family in the home. Tell me about why AAC is really important to you and how you're using it in a feeding therapy session.
In the most messy, playful way possible.
Okay.
Because, okay, so let's be honest. Unfortunately, early intervention kind of gets a bad rap, right? Like I know I have heard it so many times and they're like, oh, well, that's where good therapists go to die. And I want to be like, for those of you that can't see, I did the friend's hand gesture, but
I don't know.
no.
That's where I came alive. So you can't take it.
Yes, but this is I get to break bread with the families in their space. I get to learn their rhythm, their how they actually embrace life. And if they don't, what we can do to help, right? But unfortunately, there's so many barriers to voicing a child that doesn't have a voice. And if that child can't tell me this food hurts, or if that child can't tell me my tummy is upset, or I'm itchy because like comorbid diagnosis of like food
Mm.
allergies is through the roof, especially for eosinophilic esophagitis. Like I have to start there. Also, yes, I am a feeding person, but I am a speech language pathologist, and that's within my scope. And I'm also intimately aware that I'll go out and I'll do my eval and then I'll write up my recommendations. Please get a referral to this specialist, this specialist, this specialist. It can take 3 months to a year to get in with an ENT, with a pediatric GI, with a registered dietitian. And when we go and fully embrace our code of ethics where we say do no harm, well, I can work on the language and making mealtime safe. So essentially like addressing that psychosocial domain um, through incorporation of AAC, low tech, mid tech, high tech, while the family is working with the pediatrician to get in with the specialist, right? Um, and so that's where I start with my AAC company. So caregivers, if you're not aware, or if you're a newer SLP to AAC and you're not aware, you don't have to purchase the stuff out of pocket. You can reach out to like Forbes AAC or oh my goodness, Talk to Me Technologies just got purchased. Smartbox, is that what it's called
I
now?
think it's got purchased. Oh, I don't know, but I'll
Yeah.
look it up on the back end for everybody.
Okay, like I think it happened like within the last week, maybe 2 weeks.
Okay.
Like because oh my goodness, Jane sent me an email. Jane Peterson, if you're listening, I love you. That's my one of my AAC people. I will get that report to you by the end of this week. But um bless. But I reach out to them and say, "Hey, I want to set up a clinic trial." And then we set up the trial for the kid and their families, and food is a motivator. Play is a motivator. And so I might model on the child's device what their favorite food is, and we can count it and we can describe it. And I'll be silly, like, it's hot or oh, it's cold. And if, I'm working on opposites, they can tell me no, they can tell me to stop because are we teaching our children to have negations and to tell people to bugger off when I mean, so much language. That's that's where the Gestalt comes in. That's where the scripts and your jam comes in because I will sing and honey, you and I both know you are the voice. I can barely clap a tune, but I can sing my heart out in play, right? Um, but this is a safe way to expose and engage with a new food, a new cup, a new trial while we're still addressing that medical etiology behind the scenes.
Yeah.
And there's space to do both, and there's space to do both well and with hope. And that's what I love about AAC and language for feeding.
Some of the things that you just modeled to us about potentially like touching, going, it's hot or no, it's cold. Immediately, I heard those as really good potential gestalts because they're related to the context. You were highly emotive, high affect. You had interesting, cool prosody, and then gesture-wise, you had a whole body. I think when I'm coaching people about how to help potential gestalt stick, I'm saying like bring it to life theatrically. It's
Yes.
not just, ouch, it's hot. My body didn't tell that story. Ouch, it's hot. The totality of it told that story. And so I love that you're doing that pairing with AAC, where I would then take it to that next level. And tell me if you've done this before, is I would be, and I know there's mixed opinions on this, but what I do is I'm programming icons on there that have audio recording of my voice doing that. Or I even might program a linked video of me acting that out with the full body movement. So then it's, oh yeah.
I love this, but also because AAC is like my secondary strength, I really, really rely, and this is where like I still feel like I'm such a novice at it. I rely on Jessica with PRC Saltillo and Jane, and I'm like, hey, this is what we're working on. Make me cool. And then they train the families on how to do this. And it's free. But then they get these one-on-one times with the caregivers, and they're training the caregivers in how to do this. And so then the caregivers start training those in, or hyperlinking it to videos of their favorite shows, trying the food. Yeah.
That was one of my things on my list I wanted to talk about. Perfect. Yeah, there's a ton of free resources out there. I love that's such, and that your episodes I've listened to, that's a strength of yours is to keep linking to great free resources. AAC companies, yes, setting up for those free trainings. That's great.
Yes. Okay, wait, I have one little girl. We're not actually working on feeding, but she's a Gestalt. And when we talk about like she's hungry, if she wants a cookie, she'll turn to her mom and go, who wants a cookie from the cookie jar? And that's how, but like, who?
With the whole body reenactment, right? There's theatricality there. So that is I think that's an important part of what I think Marge Blanc talks about is like the detective work of the linguistic, like linguistically of if you're hearing a child produce spoken gestalts and maybe that's around mealtime or they're near the kitchen, try to look a couple levels deeper. Is there a connection to the raw source material that is actually related to food? Because that might give you a really good window into if they're interested in trying something new. Maybe they're withdrawing a scent from something. So paying attention to what could be 2 or 3 layers deeper underneath what they're saying. I mean, the one about the cookie jar, that might be pretty on the nose, right? So that I consider that more of a transparent gestalt, but there might be a more opaque gestalt that they're producing. Think a couple levels deeper about the food relationship there.
Yes. So on that note, I love pairing in certain children's books for food. Yes, like
okay, let's go. You're saying everything on my list. I'm so excited.
Well, but this is how we, but also this is how you tie in literacy, right?
Yeah.
And so you want to make your literacy experts happy. And I'm thinking like Dr. Kelly Farquharson, who has a ton of stuff down at
It was my
FNAP.
professor in grad school.
Are you for real? Oh my God, she is a goddess and we are not worthy. But like, yes, but Kelly does so much on dyslexia and speech sound disorder, and but between her and I'm thinking Dr. Heather Ramsdell out in Idaho. She's in Idaho. I get Idaho and Iowa backwards. Forgive me, folks. But pulling that in, it's another way to add in how many of our little ones that are autistic and have gestalts are hyperlexic. And so dragons love tacos. If you give a moose a muffin, a mouse a cookie, Yeti in my spaghetti, there's, and then there's so many cultural books about foods that represent different backgrounds, different faiths. There's a whole one on latkes that we
Yeah.
think about for Hanukkah. And so adding those in, they see representation in printed material. They see the printed word for phrases they may hear their family use. And it's amazing when the author just taps right in and describes the food and you're like, yes, because
Okay.
then you can add that into an AAC device
Yeah.
or or model it so that they have a spoken gestalt. But like there's so much good that can happen with these resources that are totally powered by a library card. So support your local librarians who are the gatekeepers of the world. Yeah.
Um, the another side of like the literacy side of it is great because you're providing these visual symbols, you're providing, yeah, the textual representation of it. On the music and rhythm side, because I'm going to bring that in.
Oh yeah.
So many children's books are written in pentameter. It's that bouncy,
Yep.
memorable way that's just very common in children's books. And I love that because for all the reasons I've talked about, where musical information is more likely going to be easier to encode, remember,
Yes.
pull out later on, because it's in this really consistent. This is what I was recently on your podcast, and it's what we're talking about. It provides this container, this mathematical predictable container for language to live inside of. So I love books like that. Find books that rhyme, find books about food that have a bouncy rhythm. So you're mentioning books that are specifically relating to food. Also, Cloudy with a Chance of Meatballs. We can't leave that one out.
Yes.
Love that
Oh,
one.
I love that movie. That is just hands down, like I do enjoy that movie.
Yeah.
And sometimes we'll go on walks. We used to pretend when it was raining that it was a pterodactyl peeing, my boys and I, like on the windshield. And I'm like, oh bloody hell, the pterodactyl got us again. And then I would like use the windshield wipers. But like we talked about food raining and all sorts of stuff. And just last week we were walking down and Bear was like, don't see any pterodactyls or meatballs today. And I was like, oh, your imagination at 11. Love this.
Michelle, I never know what's going to come out of your mouth next, ever.
Nor does my husband 17 years later.
So okay, so like real food in books, I think,
Yeah.
or that are applicable culturally or related to like muffins,
Yes.
very likely to be eaten. Latkes, very likely to be eaten certain times a year for people.
Yes.
I'm also thinking about book modifications. Because when I'm
Yes.
working with GLPs, so much of what I'm trying to do is take that special interest and then can we stretch it into other parts of life. And so as I was preparing, thinking about, again, I don't really do feeding, but if through the GLP lens, I was doing a lot of brainstorming. I was thinking about my favorite book of all time is Hungry Caterpillar because of how many GLPs love it. And there's those 2 pages that have the line of all those foods. And I was thinking about, okay, so potentially some of those could be good, like target foods at some point, maybe. But I was also thinking about like, y'all are gonna, oh, I said y'all, I always do this. I always do. I always pick up people's speech patterns. So I was thinking about modifications of it because the book itself is the container. And then can we shift the contents a little bit to match the situation? Doing a recreation of that book, but with target foods in the same order, maybe even the same style. That way, the container of Hungry Caterpillar is the same, but it's more personalized. On Tuesday, he took 2 bites of, and whatever that target food is there. So it's fitting within the container. And you could even have like a printout or a stuffed animal of the caterpillar in the session with you. And maybe that caterpillar can be really brave about something. And then could the caterpillar act as a proxy? The child can see themselves in that favorite character and maybe be a little bit more brave that day.
I have literally used that book so many times.
Yeah.
And
Great.
I have I have a picture that I use in a slideshow. And actually, I used it with a little girl who was not autistic, but she did have ADHD,
Yeah.
and she was 4. She ended up having an ultimate diagnosis of idiopathic juvenile rheumatoid arthritis that settled
Whoa.
in, yeah, her right jaw and her right knee. And
Wow.
that's why she had food selectivity, because she couldn't chew advanced foods because of how, bless her heart, she ended up having to get injections in her jaw.
Yeah.
And the only clues was that she was klutzy when she ran, and it kind of rolled funny when she did a couple sounds. But we found
Yeah.
a really good neuropathologist who got us to endocrinology, who got the
Yeah.
diagnosis. So go team. But we use Hungry Hungry Caterpillar. Um, and she didn't like her foods to touch.
Yeah.
So, appetizer trays, you can get them at Dollar General, and they came in green. And just like you were talking about, like stretching it, for her, she wasn't prepared to try all of the fruits, right? So we stretched it by finding a fruit that was similar color, or a fruit that had the skin on it, or the peel. Um, and honestly, we did modified SOS approach. So give credit where credit's due. Kay Toomey is one of the world's psychologists. She created something out of her Star Institute, is where she works, and it's called the SOS approach. It's very, very intensive, right? Um, Over the last couple years, she has strayed away from the intensity of the behavioral based approach, because of the research coming out of Marcia Dunkline, who's a leading OT expert. And Marcia was one of the first researchers to actually interview autistic adults and
Mhm.
autistic children to find out, what does this really feel like when you're going through feeding therapy? And then based off that feedback, it's been cool to see Kay like update her clinical approaches. But in a very high 30-second overview, it's touch it, kiss it, lick it, bite it, swallow it, chew it, swallow. But like, that's such a summation of like this huge, beautiful volume of research, right? But that's what we did for this little one. Is I modified it to fit her needs, and we stretched it and then built up to novel foods that she felt curious about, which is Get Curious, which is a Marcia Dunn Klein. Like, what are you curious about? And I followed her lead, because I was honoring that even though she didn't have a diagnosis of ARFID, her psychosocial domain of PFD was so high, I could see it evolving down that pathway if
Mhm.
we didn't acknowledge where she was coming from. And then, I mean, ultimately, once we got her diagnosis, heavens, yes, I understand why. Yeah.
Um, you mentioned color. I think that could be a really powerful thing to play with too. You say color, I immediately think for GLPs, I'm thinking rainbow order.
Yes,
So-
all the time.
Okay. Have
All
you
the
used
time.
that with feeding before?
Oh my gosh, yes. Pinterest is a girl's best friend.
Okay.
Pinterest shamrock springtime food trays. I mean, you'll get like really cute little leprechauns. I think they're creepy, but like whatever. Like you get all of these great ideas, but like the the rainbow foods, there's so much that you can do. And also it makes a perfect line. And
Yes.
I love a good line. There's nothing wrong with a line. Like, if they want to line their foods up, who cares?
Yep.
I mean, I watch my own neurospicy children eat. It gets in, it's safe, we're growing. You do you, baby.
And if it's, I think about it like if it's drawing the child in, then we're going to get some of that intrinsic motivation because we're leaning into the things that feel safe and good to them. I mean, rainbow
Yes.
order lined up, that those are things we continually see GLPs being drawn to. Can it be used in this other setting, this other approach? So like, yeah, choosing foods, maybe rainbow order. But I do think about, the kids that we joke about like eating only like brown or only orange things.
Mhm.
I mean, okay, tell me if this is a bad idea. Because again, I'm not a feeding person, but I'm imagining like, let's say rice is a target food. because it's very important to the family. It's just like, I don't know, it's something that's a target. I'm imagining like using or like healthy food dye, not like the dye stuff, and like a little bit of, I don't know, to create a rainbow of like little rice bites. Is that nuts? Like, does that make any sense, or is that
No, that's totally okay.
okay?
Also, it's the science,
Okay.
and kids want to know the why, right?
Mm,
Um, and there's ways to make like dirty rice, right?
okay.
And okay, I'm going to add a layer of science and then I'm going to explain it.
Okay.
There's a book called Napoleon's Tin Buttons, TIN for the metal, 12 molecules or 10 molecules that changed the course of history. And in that book, there was one of the molecules was capsaicin, capricin.
Capsaicin.
Yes, this is the word. And it's a heat, right? It's a spice. So they asked women in labor, which I've done that twice. You don't ask me to do nothing at that moment in time, but they convinced women to swallow a pill, a ball of that spice. They found it present in the placenta after birth at a
Wow.
molecular level.
Okay.
So what that tells us is that these babies are being bathed in utero in the flavors that the mother consumed, right? And one of the perks of doing home health is tell me what you ate when you were pregnant. Show me your kitchen. Show me your spices. Because we all have those spices that you can't smell. Like you walk in and you're like, I'm out. That smells disgusting. I don't want to eat that, right? But have you started with just exploring the spices that are available and then adding that in? Do your food coloring, but add
Mm,
in spices change the color of foods.
yeah.
Um, and exploring through that, the sauces, your condiments, barbecue sauce. Okay,
Oh, yeah.
like ketchup, mustards. I mean, I can't tell you how many times we've just squeezed it and put it right there so that they can see the label so that they're an informed consumer because not all ranches are the same type of ranch. I mean, Hidden Valley is where it's at, and Duke's mayonnaise is the only mayonnaise. That is the hill I will
I
die
don't
on.
know about that. I don't know. I'm kind of a ranch girl. I have strong opinions. But anyway, I'm just imagining if you know,
Wait,
you know.
now I gotta know, what is your ranch?
I'm not disclosing. I'm gonna gatekeep. So, but I'm imagining like a condiment rainbow, and that makes
Yes.
me so happy. But I was just talking to a GLP parent a couple weeks ago where it's like only chicken, only fries, no sauces, but they just kept presenting a line,
Uh-huh.
just that line, that
Uh-huh.
same order. And now the kid is exploring those and feeling
Yes.
great. Yeah.
And the sauce packets from drive-through.
Okay.
Right? So if you work in a place that has a clinic or like a communal kitchen, I would, like I do home health, but we get together on Thursdays. Okay, cool. Well, can you guys give me your sauces? Chick-fil-A sauce. We don't, I mean, I have families that will not go to Chick-fil-A sauce, but their little ones love Chick-fil-A, whether it be cost prohibitive or like belief system, right? I will
Yeah, sure.
support you. But
Yeah.
like you can ask your village, hey, can y'all gather these up for me? And can we taste test? Can we explore? And then it's amazing to see that. Like McDonald's, the sauce packets look like rainbows. Sweet and sour, Polynesian, they all have different colors on the surface of the label and then on the bottom. Um, you are spot on, but these tiny little community supports. And what's also amazing is there's one fast food drive-through here in town that I went through and I would always ask for extra packets. And finally, one of the ladies was like, why do you need And so when I told her what I did, she like straight up hooked me up with like the love, right? And one thing that we do have to acknowledge as we're talking about food play and exploring foods, that also implicitly connects the dots that there's food available to touch, kiss, lick, explore, and throw away.
Yeah.
And that's not the case for a lot of our families. Um, and this is why SNAP benefits and WIC benefits matter.
Mhm.
So two thoughts on that note that I would feel like I have failed you and I would have failed your audience if I don't acknowledge. If you have a child that is an infant and they turn 12 months of age, if they still require an infant formula, the physician can write a prescription and they can take it to WIC or they can take it to SNAP and they will connect them with that formula past the typical age, right?
Mm.
Especially for little ones that like or we're just really trying to put weight on, right? Now, if they're past the age of 2 and they need a toddler formula and whole milk, maybe they have a milk protein allergy or they just, there's a consumption problem, we can write a prescription for that as well. And then, oh, by the way, you can even get it set up through a durable medical equipment company so that it's shipped directly to them. Because oftentimes what you find is the more complex the needs of the little one that you're working for, it becomes a social determinants of health, a barrier for the caregivers to get to the
Mhm.
grocery store, to get to the places to pick up the specialty formulas versus a DME company will ship it to them for free. And so those are huge factors that God, that can open so many doors for our
Yeah,
kids.
I had no idea about that. That's
Yeah.
fantastic.
I found
Um,
out trial by fire. I mean, like I
yeah.
found out working with families and they taught me, like they have shaped that corner of my evidence-based triangle.
Yeah, I love all these resources. Um, Thinking about, because we're coming around the bend towards the end of the episode. And so I do want to create an opportunity for anyone who's listening to get in the chat if they have any questions they want to ask, or
Mhm.
we might have time for like one or two rapid coaching or just brainstorming moments. While that's happening, in case anyone does want to ask, I want to throw in a couple more ideas because I'm always talking about people love to have ideas they can use tomorrow. Just take it
Yes.
and try it.
Yes.
Um, Especially when like related to kids who have, I'm thinking about special interests. I'm always thinking through the lens of special interests. So we talked about Rainbow Order. We
Yep.
talked about potentially linking to videos you said of like characters eating
Yes.
food.
Yes.
Okay.
Bluey,
Yeah.
Peppa Pig. Oh my goodness. Yes. Although you got to watch Peppa Pig. I had one little guy try to eat out of the side of his mouth because Peppa Pig eats out of the side of his mouth, which
Yep.
we had to navigate that. But
Yeah.
yes,
That's absolutely very GLP of him to do.
it
He's like,
was.
he's like, I'm reenacting the template. What are you
Oh,
talking?
yes, very much. But he was like, and I was like, oh, let's not
Yeah.
choke.
You know what? That reminds me of a quick anecdote I wanted to mention tonight was I have a client who loves wild animals, which again, very GLP of him, loves
Yes.
wild animals and food can be a little tricky.
Mhm.
But one time he brought a leaf over and tried to make his mom eat it because that's what his favorite animals do.
Mhm.
And so that kind of sparked some ideas about using maybe videos of wild animals
Yes.
eating. And then could those animals be a proxy or a template to then engage with more types of food? And then thinking, okay, animals eating this, what could a close approximation of that be in like human form? So like we think about how many wild animals love leaves and grass, but a lot
Mhm.
of my clients are not going near green things. Could that potentially be a bridge there where if
Yes.
my favorite animal does it, I might be brave like them?
Yes, so very much. Also, oh my gosh, I can't believe there was this child that I worked with at a clinic. The owner had to close because her husband had a spinal stroke. But before she closed, I worked with this one little guy, and you can find anything on the internet. But let me preface this with, please review the videos before you
Careful.
pull it up in a therapy session, right? Like just heads up. Um, but there's Corinne, what is it when you play the sound again because it's very, is it SMR or something like that? It's very relaxing.
ASMR.
ASMR, yes. Bunny rabbits chewing carrots. There are a gabillion videos of bunny rabbits chewing carrots. And so
Yeah.
I had a little guy, autism, Gestalt, and he would tell me the bunnies, and so we would pop through and do bunny bites, or he would want to do an alligator bite if he felt very brave. And alligators, huge chomps. So we would huge chomp this, but I let him pick the animals. Hippos will eat watermelons. And you know what? If you want to do please do this maybe outside. Don't feeding therapy, you don't wear dry clean only clothes. Like I'm filthy by the end of the day, but we will, we have a lot of shout spray as well for food stains. But like a watermelon with a hippo, um, it's, there's so many ways to connect this over. And it's just, have you made the child feel safe? Are you truly seeking to understand what the medical etiology or the psychosocial components are? Are we working with the physicians to ensure that the nutrition level of the child is safe while we're introducing new foods? Do they need supplements? Do we need vitamins? Is there a time and a place for a feeding tube? I am pro feeding tube if it means the quality by mouth is joyful and happy and healing. If our bodies are being nourished and our brains are growing, it's about the balance. I hope this helps.
Yeah, and there's so many people that I think it's important to turn to for their knowledge, and that
Yes.
team approach is really important. Again,
Oh,
I think it's so important that, like, yes, feeding, I can speak for myself, feeding is in my scope. No. So like finding out
you
like
would
what
be
do you,
really good at this, honey. You really would.
I can help come up with the activities and the potential gestalts for it. I'll write you a song about kissing pieces of chicken. But finding out like who needs to be on the team, again, that kid is safe. But also I think something to mention before we start to wrap up is that people might say, no, my kid is safe. They are safe. But what about felt safety? Like that neuroception side of it is that the felt, like, you might look at like, okay, they're sitting at the table, like they're objectively safe. But if the felt safety is not there in the child, that's a
Yes.
whole different story.
1000%. But that's the psychosocial domain.
Yeah.
When we're looking at that domain, it's the child's relationship with the food, the child and the caregiver's relationship with each other around mealtime or oral consumption, and then the caregiver's relationship with the food.
Oh,
Oh, and there's
oh,
so much research about caregiver mental well-being, caregiver diagnosis of an eating disorder, trauma with food,
yeah.
ARFID, caregiver diagnosis of social media addiction, and the child having increased risks for PFD and or ARFID.
Wow.
The research is coming out of Northeastern in Boston.
Okay.
I can't remember the psychologist's name, but she works with Emily Zimmerman, who's huge feeding expert up in Boston. But yeah.
Wow. I had never considered that side of it, and it makes so much sense.
And you'll hear the caregiver's relationship with food scripted through the child. And that can be the most beautiful side. And then
Yeah.
also you're like, okay, we got to work with the mama and make sure the mama feels safe too.
Yeah.
So, but it's, you
Food is
know,
emotional. Food
yes,
is
it
really
is.
emotional.
Yeah.
Wow. Okay, let's pull back and do a quick review in our last few. So we talked about what is PFD. We've got and it's not a simple answer, of course, but there's that consensus paper available. Feedingmatters.org is going to be an important place for people to look. We talked about some of the etiologies there. I feel like there's so much more we could talk about with autism and GI and all the symptoms there. That could be another time. And then some of these ideas around like GLP focused strategies. I'm always going to say, lean into the special interest. What do they love,
Yes.
and how can you use that as a template for it? Videos, huge. Love
Yes.
using videos. Animals acting things out. What can you make a template of for that kid to then try and reenact? Lyrical replacement of of songs related to the food, textual replacement, brown bear, what do you eat? Brown bear, what do you kiss? Things like that. Sub those in and out. And then is there anything else important that, like, final words for people?
I use myself.
Okay.
If I'm their safe person, if I am the conduit to something new, and if some of my tiny humans call me Mooshell or Shell or, whatever, but if Mooshell does it and explores it, I'm comfortable with using myself as that person. So I'll film myself, on the caregiver phone right there, and we watch Michelle doing it, and or their caregiver doing it with them, or we get a film of their caregiver making the food and we're talking about it. But it ties into that best practice for daily routines and early intervention, and their scripts, and we're narrating it, and we're putting the emphasis on the healing and the hope. I
And oh, sorry.
No, I was going to say I love feeding. I love what I do, but it is bigger than one person. It truly is an interprofessional practice piece, and we have to get comfortable reaching out and saying we need to pull in OT now. We need to pull in this specialty now. The best part of my job is putting myself out of my job so that that tiny human doesn't need me. And I hope that sticks with everybody. Yeah.
We've got a lot of resources here in the chat for those of you who are listening live. For those of you listening later, they will be available in the show notes. And then importantly, if you are here joining live, please make sure you go get credit for this episode over on SpeechTherapyPD.com. If you are not a member of Speech Therapy PD and you want to make sure you get credit for it, once again, use my code Gestalt Get-Together to get your first EEU for free. Michelle, thank you so much for joining. It was really cool to have you, starting to find these overlaps, talk about how we can lean into Gestalt processing characteristics in feeding therapy. And I've certainly learned a lot from you tonight.
Oh, honey, I adore everything you do. So thank you so much for having me. This is I'm your biggest fangirl. So yay, Corinne.
And I feel like I've said it when I've been on your podcast that you are the reason that this podcast exists. So thank you.
Absolutely.
You're my inspiration. All right, everybody, that brings us to the end. I hope that you join me again in 2 weeks for the next episode of the GGT. Feel free to reach out on social media if you want to connect at crescendocommunication.com. Come on my website, crescendocommunication.com, and I'd love to connect with you and talk about all things